Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right, so life updates. I was just telling Mike that I'm learning to rollerblade right now, and I hope to still be able to use my arms for the next recording.
Don't suffer one of the foosh injury.
Oh no! Oh my gosh! Bring back to my ortho rotation.
Yeah, I actually got that when I was in med school. I actually got hit by a car, and I went over the car door, and I fell, and I had the classic pain in the anatomic snuff box, and I had the non-union. Fortunately, I healed without surgery. But yeah,
how did that happen?
Well, I was riding honestly, I was riding at sort of a standard bike speed down a hill, and then someone just opened the door. I guess I learned in the biking community this is called getting doored. So I was doored and went over the top of a Toyota Corolla.
Oh no, that's
lived to tell the tale, but I did get the foosh injury.
Okay,
which I will not forget.
All right, I have wrist guards, the elbow pads, the knee pads. If I get that, I'll be very upset because I have everything here. So
I was wearing much less protective gear. I did have a helmet, I think was important, but did not have the wrist protection.
Okay.
And I don't think I have any life updates for you on my end. No, that's not right. I do have one. I started getting back into rock climbing recently.
Ooh.
Something I did in med school a fair amount. And then some intern year, and then residency happens, and your hobbies sort of atrophy. So
and your hand, your thenar muscles. Are you sore? Are you sore?
Oh yeah, it's hard. And also, the skin is such an issue. It's almost before your muscles even hurt. Your skin just hurts from holding on to.
Oh my gosh.
It's indoor, so it's not real rocks, but they're still rough on your hands. But yeah, that's been fun. It's been a good time.
Yeah, I did a little bit of bouldering in med school. And by that, I mean 3 times. It's so fun. All my upper body strength is gone nowadays. I have atrophied since the pandemic. I haven't done any sort of gym work since third year of med school. So yeah, I would have to build up to that. But climbing is so much fun. Oh my gosh.
It's a rush, and it's also a great community. Just always really nice people there, and you're sort of working out, but also kind of working on a problem together, which is fun.
Well, what do you have for me today, Mike?
Alrighty, so I do have a case for you. I wanted to just briefly reflect on the case from last week,
yeah.
The anemia related to B12 deficiency, and it was a really, really great case. I feel like it just reinforced the fundamentals, and sort of had 3 things that I read about and very quickly wanted to share. So the first is that B12 deficiency on its own, it's rare but can cause thrombocytopenia, and this can be through 2 mechanisms. The first would be very similar to anemia. You just have decreased DNA synthesis division. So you need DNA to form the progenitors of megakaryocytes, which ultimately turn into platelets. And so sort of for the same reason, you get a thrombocytopenia. It's much rarer and it's rarely isolated, but you can see it with anemia, macrocytic anemia with B12 deficiency. And then the other one that I know has been presented on CP Solvers before is that you can get actually a pseudo MAHA and hemolytic anemia that looks like TTP, but is actually a result of B12 deficiency. Of course, that's much rarer. You would see an acute anemia, acute thrombocytopenia, like we had talked about in the previous episode, but another cause of B12 causing a direct thrombocytopenia. The next thing I wanted to mention was just you had also brought up this idea, or not this idea, you had also brought up that the patient had gastric and duodenal polyps. These are actually quite common in pernicious anemia. So it's possible that the patient had pernicious anemia and the endoscopy findings were supportive of that possibly. And of course, that would be an explanation for his B12 and other various deficiencies I remember him having. And then the last thing was this question of, in someone who has macrocytosis, when should you reach for a bone marrow biopsy, which was really kind of where I was stuck on the case. And there's sort of two reasons I think that they would choose not to do it right away. The biggest one is that generally, if someone has a macrocytosis that's unexplained, you are most worried if there is pancytopenia. That would sort of be a much stronger indication than bicytopenia or a single anemia. But those things would be worrisome too. There's an interesting, it's called the 4-factor score. It was shared by Michael Jones on Twitter.
Yeah. Oh my gosh, I haven't seen his name in forever.
Yeah. So it's at Jonesy_MA. And essentially, this is a way to sort of have this risk-benefit conversation from an internal medicine, general medicine standpoint. So it involves 4 things: an MCV greater than 96, so macrocytosis, age greater than or equal to 65, an RDW of greater than 14.5%, and then an LDH greater than 250. And you basically just rank it, 0, 1, 2, and then 3 or greater. At 0, that's kind of the base rate. About 10% have myelodysplastic syndrome, leukemia, myeloma, and that number climbs to 60% if you have 3 or greater of these factors. And so that would just be, he was 80, his MCV was certainly, it would break down here, right? But if we think it was macrocytic, then he would meet that criteria. I don't remember what the RDW was, and I don't believe I had an LDH. If we did, I forgot it. But that would be some way to kind of talk to him risk-benefit wise in like your primary care clinic about referral to hematology, bone marrow biopsy. And then the other thing is, if you have macrocytosis and you're still worried about needing a bone marrow biopsy, as I was, if you have B12 deficiency, just as happened in this case, you can actually omit the bone marrow biopsy from the workup until you've proven to yourself that the B12 deficiency is not the cause. A fun pearl is that it takes months to maybe even a year to see the bone marrow normalize after B12 supplementation. So if you go in too early after starting B12 supplementation, the bone marrow, the dysplastic bone marrow in B12 deficiency itself looks very similar histologically to myelodysplastic syndrome. Cytogenetics would obviously be different, but it's sort of a pearl that you have to give the bone marrow time to sort of resolve that process histologically, because otherwise if you go in too early, then it may muddy the waters. It may actually be what's expected for someone with B12 deficiency if you go in too quick.
Oh man, that's such epic teaching, Mike. There was a case I discussed a while ago, and I remember that someone had gotten a bone marrow biopsy in the setting of being on some medication. I can't remember if it was methotrexate, and it was for the exact same reason you brought up, which shows you kind of like how complex but how simple medicine can be sometimes. Like, okay, impaired synthesis of cells. You go in for a bone marrow biopsy, it's going to look potentially cancerous if you just look at it under the microscope. Wow, I had no idea. And the B12 polyp association had no idea. Pernicious anemia, we didn't even talk about that last time. I learned after that case, did a deep dive on pernicious anemia. Apparently, it's like the worldwide most common cause of B12 deficiency. I had no idea. I feel like in med school, it's one of those things that I just didn't learn that well and I didn't really appreciate. But that's so good, Mike.
So I have a case for you of an 80-year-old gentleman with new onset diplopia. And I can give you sort of a one-liner and the kind of brief events leading up, or I can pause here and see if you have any framework you wanted to go into right away for diplopia. I'm okay with either, whatever fits your style better.
I think probably stopping there is good because this is something I've never seen in person before, but I've seen it in a lot of clinical problem solving exercises, and I have a note on it that I won't pull up right now. So I'm going to stop here because whenever I think about this problem, I have to think about it really hard. But it's something I've read about, and I can kind of explain my approach out loud. Okay, so you have two different ways that you can think about diplopia. One is it an eye doctor's problem, and two is it kind of like a medicine doctor or a neuro doctor's problem. And oftentimes we're thinking about the latter as internists, and kind of how do you get there. So what you want to do when you have a patient with diplopia is you want to have them cover one eye, and if the patient's double vision completely resolves when they cover the eye, that suggests that the eyes are misaligned, because if you're taking away kind of the other input from the other eye that was misaligned, then suddenly your brain's like, okay, I'm good. I don't have to process kind of two things. I just see one. So that would put you in the land of kind of our world, like an internist or a neurologist world. But if you cover an eye and things are still double, then that's suddenly more like an eye doctor's issue, with one exception. So if you cover the eye, you still see double, that makes me think of something wrong with the cornea, the lens, and then where does that get processed? The retina. You have those visual tracts that lead to your occipital cortex, and that's kind of where you get back into like the neurologist and the internist land. That's I think pretty rare though. So if we're gonna have this patient cover their eye and they're still seeing double, the next thing you can do is do something called a pinhole test, which I don't know the physiology of how this works, but if basically you put this small hole in front of the eye and the rest of the eye is covered, for some reason your eye mechanics change so that it's just easier for it to like refract and bend light. So if it corrects, that suggests some sort of like lens issue, kind of like at the very front of the eye. And if it doesn't, that suggests something's going on like way in the back of the eye, like the retina and beyonds. That's if one eye is affected. If both eyes are affected, so you cover both eyes and you're still seeing double in both eyes, that suggests something going on potentially either bilaterally with what we just talked about. So like bilateral, like lens issue, bilateral kind of cornea issue, or now we're back in the neurology land, occipital cortex issue. If you have some sort of like stroke disrupting a visual pathway in the back of the brain going to the occipital lobe, the integration of information, like fusing all of the data you're getting from your retina, it just like doesn't happen anymore. Your occipital lobe just like can't do what it's supposed to do and make like an image kind of merge in your head. So that's one option too. So I'll stop there. That's kind of like the ophthalmology side of things, and as much as I could pretty much explain about that. But usually we're dealing with, okay, you close one eye and things get better, and then we're thinking more of eye misalignment. And we could I'll just stop there. We can dig into that after your next aliquot.
I think that's perfect starting point. Really, like the entire differential of diplopia flows from binocular versus monocular diplopia, which is of course figured out by covering one eye and seeing what happens. So this gentleman, you're actually seeing him for a second time. He was just here in the emergency department about a week ago. At that time, he came in after experiencing 15 minutes to 20 minutes of a sharp burning sensation sort of from the right ear to the right eye. And that was accompanied by sort of the same duration, 15 to 20 minutes of horizontal diplopia, so images that are next to each other. He basically lay down for a period of time. These symptoms both resolved entirely. And he was relatively worried in general that just happened. It never happened before. So he came into the emergency department. This was a week ago. At that time, neurology was consulted. He had basically came in as a stroke code, had the full stroke evaluation. Actually, he had all CT imaging. He didn't actually have MR, but had a CT non-con and then also CTA. And at that time showed an age-indeterminate occlusion of the proximal right V4, so the vertebral, with collateral from above and below. From above. He had moderate to severe narrowing of the right cavernous and clinoid internal carotid artery and moderate narrowing and origin of the left MCA. And all of this was read as chronic atherosclerotic changes with no overlying acute changes. He did have mild ventriculomegaly that was consistent with age-related volume loss. And the brainstem specifically was described as, normal without any changes. He had lab work done at that time, which was unremarkable. And his vitals at that time was notable for a mild tachycardia to the low hundreds, like 100 to 110, otherwise stable vitals, afebrile. Because his symptoms had resolved and did not recur in the emergency department, he was actually just treated with, sent with some Tylenol and I believe ibuprofen, sent home and asked to follow up with neurology outpatient, and basically sort of thought that it was a primary headache disorder, and they would try to see him as soon as possible outpatient. He's now coming back to you now with essentially the same symptomatology, but on the left side. So he had a same sort of symptoms, sharp pain from the left ear to the left eye, followed essentially with left horizontal diplopia. Lasted about the same period of time, pain and the diplopia together, and then resolved entirely again. He's coming in now after that has resolved, has not recurred since he's been in the department. And he, so he's back to baseline in terms of pain and visual symptoms. This time he's a bit different now. He is febrile to 102 degrees. He's tachycardic now to the 130s, 140s, and fortunately still stable. His labs show a mild leukocytosis, otherwise normal CBC. His BMP is also normal. And then he has a mild elevation of transaminases into the sort of 80 to 100 range, AST and ALT. It's ALT predominant. And those are sort of the labs that you have at this time. And
wow,
we can start there and ask what questions you have.
Wow. Yeah. I think what I'm going to do what I just did for the kind of ophthalmic side of things, and just start from the beginning of how you can kind of get this sort of diplopia, and I think kind of ask questions as I kind of go along that tract. We have to try and localize the lesion here is what we're doing. So if we're saying that this is a neuro issue, how can the eyes get misaligned? Well, really quickly, you have to think about physical misalignment of the eyes, not structure. I'm sorry, not neurologic, but literally something causing the eyes to kind of be physically deviated. So stuff inside the eyeball, pseudotumor, things like this, recent trauma, anything that will physically push one eyeball, away, can do that. That's kind of one big bucket for how the eyes can get misaligned. It doesn't sound like that's the case here because pathologies, it sounds like migrating from the right eye to the left eye. So that doesn't make any sense. I would kind of expect that to be much more chronic. So I am thinking kind of more in the true neuro realm of eye misalignment here. So how do you move your eyes, and how can that kind of get disrupted and cause misalignment? You mentioned the brainstem. This is where your eye muscles are their innervation is gonna begin, is the level of the brainstem. So what can happen there? You can have ischemic stroke, demyelination, hemorrhage, things like this. But it sounds like, at least on the initial presentation, we didn't get an MRI, which is much more sensitive for, for subtle strokes. So we can kind of talk about that again. But for now, we can maybe label this as like an image negative kind of etiology, and maybe we're not thinking so much brainstem. So okay, that's where your cranial nerves kind of like take off from. So then what cranial nerves then affect your eye? So you have the third nerve, which does a bunch of things, which I'll get back to. The fourth nerve is interesting. If you like snap your fingers kind of like at your wrists, and you look that direction, that's kind of what it allows you to do. That's how I remember it. Neurologist taught me that in med school. The sixth cranial nerve allows you to look laterally. That's your lateral rectus lateral rectus muscle. And then cranial nerve 3 does everything else. That's kind of how I remember it. So if I recall from my notes, I kind of some buzzwords in terms of localization of those findings. I remember like driving is often difficult with double vision. If you have a sixth nerve issue, because you're looking laterally a lot when you're driving, like into the mirror. So if you notice when you're driving, you're having a lot of double vision, that may make you think of nerve 6. If you're going downstairs and you have issues, and that's because you're like trying to look down, that's often a cranial nerve 4 issue, which, remember that if you snap your fingers near your hips, that's where that allows you to do. Cranial nerve 3 is a bit interesting because it has other non-motor actions. So you have that parasympathetic. You have the parasympathetic fibers overlying the nerve, right? So if that gets compressed, your eyes. I know your eye will dilate. Mydriasis. Your eyes will dilate if that happens. So if you're losing parasympathetic tone, that will allow that to happen. Okay, so that makes sense. It's cross-checking my brain how that works. So a clue to, if you're thinking cranial nerve 3 and you're trying to like localize the lesion for that even further, like is it a nerve compression issue or like a nerve infarction issue? If it's accompanied by like a fixed dilated pupil, you're thinking more compression. So knowing about this patient's pupils would be kind of interesting. What's interesting is you told me that it was horizontal diplopia. So I don't know if that helps us get to 6, but just because we're kind of in that space, did the patient have any pupillary kind of abnormalities?
Great question. So yeah, at this point, he again is back to normal in terms of his symptomatology.
Oh, okay. Yeah.
But yes, his full cranial nerve exam is negative, normal.
Okay.
And he does describe that when he had this episode, he's a really kind of smart guy and pretty medically literate, and did some research on his own. And second time it happened, he knew to cover one eye. And it went away when he covered his eye the second time. So he tells you that. He's very excited to tell you that he did this research, and he's absolutely right that's the start. So he's given you that nugget. And he otherwise, there's nothing sort of obvious on the neurologic exam. You sort of checked your exam with the neurologist's exam a week ago and don't find anything different or new.
Okay. Got it. Yeah, we definitely need to layer on, after I'm done running the neuroanatomy, we definitely need to layer on the fact that this is so intermittent. That's super interesting. Tempo is always queen. Okay, we finished the cranial nerves. After the cranial nerves, you have your neuromuscular junction. Localizing to the neuromuscular junction, you can think of fatigability. So if you have people try and sustain lateral gaze, so like look to the right and have them hold there for 30 seconds and diplopia gets worse, that would be a suggestion of myasthenia. Lambert-Eaton is, that other neuromuscular disorder you can consider. That's kind of the opposite of that and often paraneoplastic. Other ways your neuromuscular junction can be disrupted, organophosphate poisoning is kind of that fun etiology. If you have that exposure to like fertilizer, you're literally poisoning kind of the synapse there. And then finally, okay, you plug into the muscle. The only thing I can think of is thyroid eye disease doing that. Let's now take a step back now that I've run the anatomy. Like, what are the localizing factors you've given me here? Horizontal diplopia, okay, it's cranial nerve 6. The tempo I don't think can help me yet. The I'm going to layer that on at some point. The what am I thinking about? Oh yeah. This pain is so interesting. So if you're telling me it's running from the ear to the where exactly again? Can you show me? It was from the ear to the nose.
So he describes it sort of as the, essentially ear canal to the corner, the lateral corner of the eye. And he describes it as sort of a sharp burning sensation that lasted for 15 minutes along with the diplopia and then resolved entirely along with the diplopia resolving entirely. They were sort of co-occurring.
Okay. So that's really interesting. I mean, that location to me sounds like V2 of the trigeminal nerve, because that's split into three parts, trigeminal, right? So like the forehead and then like the middle of the face kind of going to the eye. It's much more specific than that. So I don't remember where exactly this ends. And then V3 is kind of like, the chin and the bottom part of the face. So it reminds me of that. But what's curious is that doesn't, of course, control your eye movements, that nerve. So I'm trying to reconcile that. Why would a 6 issue cause a sensory issue? That's a pure motor nerve. Please, Dr. Byrne, don't burn me on this. Like 9 years later, but I think that's a pure motor nerve. So I don't know why that would be painful. But it certainly sounds like it could be a 6 issue paired with a V2 issue potentially. Now that is interesting, because if you start bundling cranial nerves together, then you start to think, okay, where do these things kind of like lie together? Ones that run through the cavernous sinus are 3, 4, V1, V2, and 6. And then you have these sympathetic fibers that go through too. So, in terms of like nerve pairings, if we are going to pair kind of this sensory issue and maybe the V2 distribution, that's how I'm analyzing it. I may be completely off base here. I'm very open to you telling me something else that'll send me in a new direction here. But if we pair those two, then it makes me think of the cavernous sinus and potentially a brainstem issue that was missed. Another way we could layer on information is it sounds like the patient has inflammation. So there's tachycardia. You said fever, and did you say leukocytosis? I don't remember.
Yep, that's right. He has leukocytosis, about like 14,000.
Okay, so he has multiple signs of inflammation, and is this related? I'm keen to try and tie it all together, since this is all happening kind of so quickly. It's also possible this is a guy we don't know too much about yet. I forget if he said he was healthy, but maybe he's incidentally sick and having something else going on. But I'll try and tie everything together. The other way you can tie things together in terms of multiple cranial nerves being affected is meningitis. So your meninges are connected, or your nerves rather kind of run through your meninges. So if your meninges get inflamed, you can have multiple kind of cranial nerve deficits kind of line up. And what we're seeing here is kind of the right side going to the left side, and these kind of like nerve bundling. Like it seems there are 2 nerves involved, 6 and potentially V2, and I'm happy to be proven wrong. But I'm rambling. What would I do next? I guess that's the big question. It's a hard case. Honestly, I'm thinking early for this guy, just because of the inflammation. I mean, I've never seen a case like this, but I'm going to put LP on my list of things to kind of consider, just because we're seeing these signs, and it's such a neat way to kind of tie everything together. More sensitive brain imaging is the other thing to consider. Like, is there something we missed in the brainstem where all these things kind of originate? I'm less inclined to think that, because this has fully resolved and also changed sides too. So that would be a little strange, unless if there was some sort of like demyelination that's kind of like jumping around a little bit. But this all seems so quick. He said it only lasted 15 minutes and then fully went away. So I'm really not inclined to think that this is kind of like a structural like tumor or hemorrhage or stroke in the brainstem. I'm thinking this is more kind of like it sounds like a nerve issue. And it's not, we need to do a couple exam findings just to triple check, make sure there's no fatigability. But honestly, I don't know why. I'm just thinking kind of like nerves, and what could be affecting them. And perhaps the advanced imaging would also shed light on perhaps like inflammation of the meninges on MRI actually, and kind of that space where all the nerves sit. So yeah, I would think probably those two things, if anything, in terms of like very targeted tests. But otherwise, I'm doing like you know general workup for meningitis and sepsis. I think in this patient, which I'll stop talking here.
Those are all the exact thoughts that we had in the emergency department as well. It's really scary when you have acute neurologic changes at the same time that you have new inflammation. So we were just as worried as you were of all the same things you mentioned. I have some of the data for you. So MRI brain was done on an emergent basis, and it shows moderate to severe non-expansile T2 hyperintensity in PONS without mass effect or diffusion defect, consistent with chronic microangiopathic changes, non-specific white matter disease. He does have bilateral mastoid effusions, which are mild, and then specifically negative for meningeal enhancement or encephalitis, hyperintensity that would be consistent with encephalitis. So you had mentioned that, and then the other thing you had mentioned was an LP, which sort of at the end of the case, you'll know why, but we don't have an LP for this gentleman. But it was a question that we asked as well, and ultimately other things sort of revealed themselves before we had to go to that. But it was also something we were ordering and thinking about doing.
Wow, super interesting. So we were right. There wasn't something anatomical in the brainstem. This finding of bilateral mastoid effusions, anytime I see this idea of like bilateral infection always makes me skeptical. Like bilateral cellulitis is never a thing. Is someone at risk of bilateral like ear infections that's somehow related to all this? I've never heard of anything like that. So I'd be reading about that. And I don't know what I would be doing next, Mike. This is tough. We've done the imaging. This is resolved as well too. So it sounds like we may be kind of at that point in the diagnostic arc where in 24 hours, something very obvious is going to pop up, and the way that this evolves is going to help us. This sounds like it's very challenging to diagnose up front. There could be an illness script I'm missing here, but it sounds like the time is going to be the best diagnostic test here. So what happened next?
Yeah, I think that was just such a great discussion. And I want to give you just a bunch more data now as sort of the second aliquot. And I think this will sort of shift things. The case was interesting in that we did not get sort of all the history on the first pass. And it took multiple iterations of sort of asking questions in different ways to kind of get to this second aliquot. So it actually took us the 24 hours to kind of get here as well, not just watching him, but also re-interviewing. So he will tell you, this is a gentleman, I should just mention, we didn't discuss his past medical history. He has coronary artery disease with PCI decades ago, type 2 diabetes, and has long-standing persistent AFib that's rate controlled. No recent changes to medical history. He's an avid outdoorsman, even in his 80s, hiking and backpacking, and he has this big garden that he loves to work on. He tells you specifically that he picks ticks off of himself every day after coming back. Just a fun fact. And he does mention, and his partner also mentions, that over the last couple of months, he has just been a lot more run down, is the way he describes it. Partner describes it as profoundly fatigued. And that sort of has been going on for a couple of months now, really has reduced his level of activity over these months. And that's sort of one thing. Additionally, he basically has had some trouble with kind of touching his scalp. He is not. He's able to sort of reach over his head, but he's having a lot of pain when he's like combing his hair. He's getting a lot of pain with combing his hair. He's actually to stop combing his hair. He doesn't have a lot of hair to comb, but he's not been able to comb it. And it is worth noting that he actually is kind of disheveled in terms of his hair when we interview him. He otherwise, I think those are sort of the big things. He has a lot of stuff sent that I don't want you to have to guess for too many things. So he has a procal that's elevated, mildly so, but elevated. He has negative tropes. I mentioned he has tachycardia. He's just in AFib with RVR in the 120s, 130s. This still persists 24 hours later. He has had really a pretty extensive negative workup for infectious causes. So, culture have all been negative. Blood and urine did not make any sputum. Chest x-rays negative. His exam is negative for any signs of meningismus, and really his exam's negative overall. He says he feels sort of weak, but we're not able to elicit any weakness on exam. And the sort of other things important to know that the TSH is normal, and his, let's see here, you had mentioned, just want to make sure that I get the things that you had mentioned. So he did get specifically tested for myasthenia with the AChR antibody, which was negative. And I think probably the most notable thing is that his ESR is 70 and his CRP is 298. I'm going to stop there. Any other data you want, you're welcome to have, but I'm going to take a pause there.
Yeah, we didn't. I mean, tying together a low grade transaminase elevation and aliquot 1 kind of I didn't think would bear any fruit in my approach to diplopia. That's not all in my approach. Now it's interesting giving this kind of like the social history. And remind me, the CBC, were there any cytopenias on that?
No, actually, no anemia, no thrombocytopenia, and a mild leukocytosis to like 14, 15. I think it's gone up maybe by 1,000 on day 2.
Okay. Got it. So I'm just going to forget about the diplopia for a sec, because we're talking about, is this related or is this not related? So let's just like take a step back and stop trying to tie it together. So this is a guy with blood culture negative inflammation that's legit. Like he's not feeling well. He's super tachycardic without an explanation. And at this point, you said he's still tachycardic. I'm assuming he was put on like non-doxycycline. He's still in a doxy deficient state kind of at this point in the admission. And he's like not doing so great, not feeling so well. Is that right?
So we've actually not treated him with any antibiotics at this time.
Okay. Got it. Okay. I was trying to see if I could use that to kind of stratify what sort of infections could be going on. But I don't know, whenever you say, low grade transaminosis and a guy who's pulling ticks off of his body, I've never heard that one before. And in the Northeast where Mike is located, you have to think of tick-borne diseases. And these would not be responsive to like, your vancomycin zosin. These are doxycycline responsive diseases. Hence the question, is he doxy deficient? I ask about the cytopenias because you think of babesia, and in that case, that would have been completely unrelated to diplopia. In that case, you'd be talking about like this acute hepatocellular injury, ARDS, altered mental status, but diplopia is like not on an illness script. But the lack of cytopenias here doesn't add up with that. Lyme disease, when you started talking about diplopia and pulling off ticks, suddenly Lyme disease kind of came to the forefront because that can cause cranial neuropathies. That tied into the transaminosis. I've never heard of that. I wouldn't be surprised if Lyme can do that, but certainly I'm going to test for it at this point. Anaplasma and Ehrlichia, other tick-borne diseases that are located in the Northeast, cause transaminosis. Usually you can see like leukopenia with that. On the smear, you can see these bugs inside of the white cells. Neuropathies, though, and in terms of, again, trying to tie this back in, I'm not sure. So I'm almost beginning to wonder, Mike, if this is kind of that hypothesis B where this guy came in with a diplopia issue and an infection, honestly, because it's kind of getting hard to tie together other than the Lyme disease hypothesis. I mean, routine infections are not going to kind of cause this. You told me there are no signs of meningitis on the MRI. So if it's truly like a nerve issue, like sure, maybe that may like pop up on an MRI, but probably not if it's like, not unless if it's fulminant or something like that. So still thinking if it is tied to an infection, still thinking it's like really a nerve issue, like cranial neuropathies, maybe from Lyme disease. Sounds like we've done a pretty good exam, no fatigability. When he told me he's like been getting weaker and weaker over the past year, I was like, oh, is this guy fatigable? Like, is he just like getting more tired throughout the day and it's getting worse? So he just like can't do his activities from myasthenia, but we tested for that and it's negative and he doesn't have the fatigability on exam. Oh, one question I had, you said it was painful for him to raise his arms to the scalp and that's why he's not doing that, or he's weak and that's why he can't touch his scalp.
So it's actually the contact of the comb with when he's combing his hair that he's finding very painful.
Oh, well, that's interesting. That's neuropathic, sort of pain, and hyperalgesia is that kind of sensation of pain to light touch out of proportion to what's going on. You're not getting hurt, but your nerves hurt. Hyperalgesia is that. And it sounds like that's been going on for a while as well. So yeah, this is a tricky case. I'm still at a point where I'm not sure if these issues, the diplopia and this underlying seeming infection are related or not. With the blood cultures being negative, I'd be sending the tick-borne studies we talked about. It's not going to be Babesia. If we want to save the patient money, we're not going to send that. Lyme disease, certainly. And anaplasma ehrlichia, not on my illness script, but just given the transaminosis and how sick he is, I'd be sending PCRs for that. And yeah, what do you have next, Mike?
Yeah, no, all the things we were thinking of as well. So I have a bunch of things for you. Lyme was tested negative. Ehrlichiosis was not tested. Babesiosis actually was tested and was negative. Aseptic meningitis was considered. I mentioned that we don't have an LP at this time or ever, but enterovirus and echovirus were sent PCR from the blood. It's not as sensitive, but it's relatively sensitive. And these are common causes of aseptic meningitis in the time of year that this presentation happened. So those were also negative. He had a West Nile virus that was sent as well that was negative. ANA negative. He had an AMA and anti-smooth muscle were sent because of the transaminase elevation, which were negative. He had a p-onca sent that was positive at 1 to 20, which was not considered. It did not reflex any further because the lab did not find that to be actually a positive value. And an extended viral panel was sent that was also negative. And I believe other than that, HIV was negative, CMV negative, Hep A, B, C, all negative. And I should mention that the reason that antibiotics haven't been started is because there's no recurrence of these neurologic symptoms since he's come to us. And he has no other localizing symptoms at all that have presented themselves on presentation or through the last 24 hours. And so with a differential so broad and including a possible meningitis, we sort of didn't want to antibiose him to really just hit him with so many different things when we don't really even know what we're treating. And though he's still inflamed the next day, he's about the same level of inflamed. He's not worse. And I should mention at this point, we do have ophthalmology see him just to make sure that there's not some, primary ophthalmologic process going on, and they do not see anything abnormal on their fundoscopic exam bilaterally. I'm going to pause there again and see if there's any other data you would like or anything that's changed.
Oh, my initial impression is I'm double visioned right now. like where are we? I'm having really hard time coming up with reflex thoughts on what to do next. And we can run the inflammation schema and try and see if something non-infectious kind of pops up here. I mean, we haven't talked about malignancies doing this. This guy's been more fatigued for a while. Doesn't sound like he's been losing weight. This would be very, very unusual presentation. Autoimmune diseases, there's nothing, you just said in terms of infection, there's nothing localizing. Sounds like there are no other kind of like rheumatologic symptoms like joint pains, malar rash, anything like that. He's not on any drugs. This is not an endocrine presentation. So I'm still wondering if there's an infection we're missing here. And I'm really stuck on this like nerve description, the pain. What does this mean? Does he have some sort of like VZV reactivating, and he hasn't developed a rash yet? But this has been going on a while. The pain on the scalp, right? It's been a couple weeks.
So the presentation is about a week old, but it's really just 2 episodes a week apart. Again, switching sides, one time an electric shock on the right ear to eye with the diplopia. That resolves entirely for 6 days and then recurs on the left side, same sensation, left ear to left eye, with then the same electric shock sensation, diplopia, that both then resolve simultaneously by the time he comes into the emergency department again.
Okay.
And there's no residual symptoms since he's been in the hospital with us. We've not been able to capture this. And he's a good reporter. He tells you everything.
And the pain on the scalp, that's still there? Or in the past, it was there prior to the diplopia, this pain when he was combing his head?
That pain has been there for a few weeks to a month, maybe. We're not able to elicit it on our exam, though. But it's something that he mentions and brings up multiple times.
Okay, I don't know what to make of that. Yeah, Mike, I'd be consulting neuro here. I'm totally stuck. I wonder if I don't wonder. I think really probably this cyclic nature, rapid on, rapid off, is going to be helpful. The neuropathic kind of signature, I think, is going to be very useful to the final diagnosis. And let's see. What else? Yeah, that's all I got. That's all I got, Mike.
Yeah, so we involve neurology again. And interestingly, we got sort of a similar answer that, they did not think that T2 hyperintensity in the brainstem was related. They asked for the myasthenia workup, which is, was the reason that was pursued and ended up being negative. And then sort of in talking with them, we at the same time kind of said, okay, there's one other sort of thing that's going on here, and that's that he has sort of this tenderness in his scalp, if we're going to call it that. And, he's 80 and his ESR is, climbing, his CRP is almost 300. Is there some sort of vasculitic process that would be, ANA and ONCA negative? And, we were sort of worried about, giant cell arteritis. And so we reached out to rheumatology with the question of biopsy or no biopsy. How worried should we be about something like temporal arteritis or giant GCA? Because obviously, you have to start treatment early, and it's a vision-threatening diagnosis. So they actually feel that this is relatively consistent with GCA. They feel that his weakness is probably PMR, but not really kind of the classic illness script for it, but the time frame sort of fits. And so they recommend a temporal artery biopsy and initiation of high-dose steroids. I'm going to pause there and hear your thoughts, and then I'll go to the biopsy.
Yeah, I think there are just a lot of discrepancies in my illness scripts compared to what I was hearing from this patient that wasn't even on my radar. Like the description of like pain, the kind of light touch I was framing as a neuropathic issue, but I didn't kind of think of kind of like the true like vascular issue. Also like that shooting sensation from the front of the ear to the front of the face. I think more of like I forget what it's called when you have pain when you're chewing, but pain on chewing, like an effort issue in terms of, vasculopathy. and not so much of like this nervous issue. So just the way it was described, the way I processed the information, just totally didn't line up to my illness script for GCA. Of course, this high ESR and CRP without an alternative explanation certainly could line up. GCA is one of those conditions where ESR can be greater than 100. It's kind of that fun DDX where ESR is greater than 100. But in trying, if we're going to invoke GCA as a cause of the diplopia, how do we get here then? Like, why is he having the diplopia? A GCA can cause or I'm sorry, no, where I was about to say that I'm going to pause. I was about to say that GPA can cause pseudotumors, but and go down that train, but that's not the case. But in terms of trying to synthesize the diplopia with giant cell arteritis, that would be very challenging for me. I mean, that's a vascular issue. It's a large vessel vasculitis. And how can that inflammation affect cranial nerve 6, I guess, is kind of the question. If we are going to call this really a transient cranial nerve 6 issue, I mean, does that blood vessel run very close to the nerve and it's just continuous inflammation kind of causing this? And it's just a mild irritation and kind of the pain is going away. That's my initial reflex, but Mike, I'm just going to learn from you. This is such a cool case. Thanks for bringing it. What do you have? How did this end?
So my team, me, the neurology team, I think all of us noted the age and the ESR and CRP. And then, there was no jaw claudication. We weren't able to elicit any proximal weakness. We, we couldn't actually get any tenderness on the scalp, even though he was sort of describing that to us, I guess, in retrospect with the comb. But we couldn't reproduce it. And it was a challenging history also. I mean, there was a lot of information to sort of sift through. You'd be in the room for an hour and a half. And it was hard to piece out what was important and what wasn't, because there was just so much data that he was presenting to you. So we do start high dose steroids. Of course, he's not having any symptoms at the moment, and so therapeutically we won't know from the presenting symptoms if this will resolve. But I will say that his tachycardia improves and resolves after a couple of days. And the, overall feeling of profound fatigue starts to resolve. And he overall just starts to feel more well over the next couple of days in sort of a non-specific way. And his ESR and CRP, half within the first 24 hours and then, continue to fall there afterwards. It takes a long time to get the temporal artery biopsy in patient. I think day 4 or 5 it took to actually get it all organized and done. And he actually gets bilateral biopsies because of the fact that his symptoms were on both sides. And the left side is indeterminate, but the right side does show giant cell infiltration consistent with temporal arteritis, and makes the diagnosis for GCA.
That's insane. How did you guys tie together the diplopia?
Absolutely. Yeah. So this was like this was the learning point for this case for me. There were so many, but the big one was that it was not in my illness script at all, but diplopia is a common presentation of GCA that we don't really learn about. So,
oh my gosh.
There's lots of different ways to kind of teach this. I'll give you a few. So the first is that in the emergency medicine literature, in terms of triage of diplopia, it starts with, monocular versus binocular. Just to review, if you cover your eye and it goes away, that's binocular vision. If you cover your eye and it remains, that's monocular vision, just like Andrew said. If there's other neurologic issues you do a stroke workup, and you pretty much always are going to do a stroke workup in the emergency department if someone comes in. So certainly someone with vascular risk factors and in their 80s. If it's isolated diplopia, actually the next thing to do in someone who's greater than the age of 65 is actually to get an ESR and CRP.
Wow.
Which it was not at all on my radar. And then from there, you would, if that's negative, then you go down sort of the neurology, cranial nerve pathway. But if that's positive, then you're much more worried about GCA. So that's one way to get there. And actually, in the emergency medicine literature, all patients greater than 50 presenting with new onset diplopia should undergo ESR and CRP testing, is a recommendation. Additionally, in the rheumatology literature, diplopia actually has a positive likelihood ratio of 3.4. If you're otherwise concerned for GCA, I think the problem here was that our pretest probability was really low. So the positive likelihood ratio of 3.5 even if we knew that, which we didn't, would probably not have moved the needle so much, right? Because we got far less than 50% likely with the presentation. The jaw claudications 4.2 positive likelihood ratio, temporal artery beating or enlarged or painful, all of those things are sort of in the positive likelihood ratio of 4. But again, likelihood ratios are only as good as your pretest probability, and we didn't really have one here. So those are some other interesting things, but diplopia is a described cause, a described presenting feature of temporal arteritis. And then the sort of last thing is this description of scalp tenderness that I wasn't really looking for or thinking of, right? So he's describing that combing his hair is painful. You generated more of a differential than I did for that. His shooting pain in his temporal region, it's, in retrospect, it all kind of makes sense. He's having temporal artery headaches with diplopia, with painful, scalp tenderness, and an ESR of, 70, CRP of 300. He's 80 years old. I mean, it really, when you go back and you look at it, it's sort of like, oh my gosh, how did we miss this? But the way it presented to us was so outside the realm of our understanding of in terms of an illness script for this disease. So, it's interesting because the literature actually supports that diplopia is relatively common, but I certainly, and the neurology team also, were not aware of this. And both of us very quickly, both notes from the admitting team, the emergency medicine team, and the neurology team all mention giant cell arteritis is possible, very unlikely, written sort of 3 notes. And so, briefly considered, but very quickly dismissed. And most notes said because no jaw claudication, no scalp tenderness.
Wow.
And, so I'm going to stop there and see your reflections. But those are the learning points for our team.
Yeah, I have 2 big reflections. But before that, a question. Is there like a neat way that this affects that kind of like neuroanatomy framework? Like how does this happen? I'm still stuck on why does the diplopia happen? Do we know?
Yeah, that is like the next big teaching point. So you set it up really well. So the ocular manifestations of GCA are actually relatively, there's actually more than just vision loss, which I think is how we learn about it. And of course is the most scary consequence and why you start steroids before biopsy. But there's actually many ocular manifestations, and it really is just about what comes off of that, off of the arterial supply. Of the external carotid that then has all those branches, right? And one of them being the temporal artery. So, most commonly you get vascular disruption to the the retinal artery. And, that's kind of classic, right? That's what gives you your ischemia. That's the most feared complication. But, that same blood supply is fed by, is involved in the extraocular muscles. And those sort of things can also cause things like diplopia what looks like a cranial nerve palsy. And so about 20% of cases actually have a cranial nerve 6 palsy as a result of what's felt to be actually extraocular muscle involvement rather than cranial nerve involvement. And
Mm.
so you were spot on in terms of the anatomy, walking from the brainstem all the way out to the eye, and that last, link is the actual muscle itself. And, you can, of course, consider, the things that break down the neuromuscular junction, but the fact that you actually can get like a myopathy itself as a result of kind of intermittent ischemia. And then vascular surgery actually felt that the reason he was having these symptoms the way they, it was obviously bilateral probably, right? Even though we only had biopsy proven on one side. But really you get a lot of vascular spasm with this process. And so it's likely why he was having this sort of maximum intensity for 15 minutes and then complete resolution, that this was probably relatively early in the natural history of GCA, which is maybe why the temporal artery biopsy was indeterminate on the left. It also could have been because of the exposure to steroids. But we may have seen sort of this was sort of really early in the natural history of GCA. And so you were just getting essentially spasms because of this really temporal artery. And so that was giving you these electric shock headaches that were, that's sort of where things were.
Oh my gosh. So many reflections. So it sounds like, we're trying to tie together like multiple nerve issues. Like where do the nerves kind of run together? We kind of ran that. What we didn't run was what you just said, the vascular supply of multiple nerves. That's something I'm going to add to my script. I mean, super, super duper rare. And it sounds like pretty much GCA is kind of almost like pretty much probably numbers 1, 2, and 3 for this sort of DDX if you come into this sort of issue. Super interesting. Number 2, the cyclic nature. I love that explanation by the spasm. That fits neatly into this framework we have at the CP Solvers on sudden onset symptoms and things that resolve. We talk about blockages of lumens happening, and a vasospasm is like a blockage. That's a very sudden onset, phenomenon. We talk about lumens tearing, causing sudden onset symptoms that would persist, and then changes in electrical activity, seizure. And in the middle of your case, I was like, are these seizures? And I was like, no, this doesn't make any sense. But those are kind of the 3 things we think about the CP Solvers for kind of like sudden symptoms, and the vasospasm totally makes sense for tying in the timing of this. Okay, I think the final thing is the power of the frame. I mean, it sounds like all of us, we just weren't framing what this gentleman was reporting to us in the way that would be most productive for our clinical reasoning. This would have been so easy if you just had jaw claudication. And yeah, it's so funny that V2 distribution. I was thinking that's totally slam dunk V2. It was just coincidence. You have to be open to the possibility of other things going on. So anyway, gonna add this to my notes. Thank you, Mike. I think the listeners are gonna love this one, and I'm looking forward to the next one.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.